Hi, my name is Natalie Whitkin, and I'm the Director of Partnerships and Programs at Willow. I'm very excited to be here tonight and to be able to introduce our first guest speaker, Dr. Kelly Metcalfe. I have the honor of introducing her. She's both a colleague that I've worked with a number of times, so it's nice. This is a nice honor. She's a professor of She is a professor in the Lawrence S. Bloomberg Faculty of Nursing and an adjunct scientist at the Women's College Research Institute. Dr. Metcalfe's research focuses on the prevention and treatment of breast cancer in high-risk women, most specifically with BRCA1 and BRCA2 gene mutation. She's currently leading a multidisciplinary study to assess the provision of rapid genetic testing for BRCA1 and BRCA2 at the time of breast cancer diagnosis. This would allow those results to help inform a woman's decision-making. Dr. Metcalfe holds research funding from the Canadian Institutes of Health and the Canadian Breast Cancer Foundation. So without ado, she's going to speak.
Thanks, Natalie. And thank you again for the organizers for inviting me to come and talk today. I think it's nice that we can integrate the research and the clinical and bring it to the people who need this information the most. So I'm happy to be able to share some of the latest research with you as perhaps you move through your decisions about decision-making regarding breast cancer prevention and perhaps treatment if you're high risk. So we've all heard a lot about BRCA1 and 2 in the media recently over the last 18 months with Angelina Jolie coming out about her decisions and those being difficult decisions for her and her family to make regarding cancer prevention, both breast and ovarian cancer prevention, after she was identified with having a BRCA1 mutation. So I think we've heard a lot about it. We are all aware of some of the options that are available to women who are identified as high risk. So I'm going to try and summarize some of this research today and talk to you a little bit about some of the more recent research that's come out, looking at the impact of some of these preventive options for women who are at high risk in terms of preventing cancers and ultimately having an impact on mortality, because that's what we want to do. We want to increase survival in these women who are identified as high risk. So we all know, and I don't have to give you the numbers, that breast cancer is common. It is the most common cancer in women here in Canada, and approximately 1 in 9 women will be diagnosed with breast cancer in their lifetime. And I'm not going to go through these numbers, but I just want to give you an overview of what some of the risk factors are. So when we talk about risk, what makes someone high risk as opposed to someone else? So how can you and your neighbor be at different risks? There are various risks. Some are lifestyle, some are choices that women make about alcohol, body mass index, things like that. So you can see that these numbers really aren't that big. Some of the bigger relative risks are for women who have had a biopsy done where they've been found to have atypia and may have a family history. Because when we think now about relative risks, this is where I think we can see that by identifying women with a BRCA1 or 2 mutation, we are identifying very high lifetime risks of developing breast cancer. And so I'm going to focus the rest of my talk on that. But you can see, for a woman with a BRCA1 mutation in the age group of 30 to 39, she's 36 times more likely to develop breast cancer than the average woman between the ages of 30 and 39. So these are very elevated lifetime risks of developing breast cancer. So when we identified these genes, we were then put in a position to try to prevent breast cancers and ovarian cancers from happening in these women, or at least reduce the risk of these cancers happening. We know, though, that the majority of breast cancers are not due to these 2 main genes or any other genes that may cause cancer. The majority of breast cancers are sporadic, so 90% of breast cancers are sporadic. But the 2 main genes that we know the most about, and that's not to say that there aren't other breast cancer genes out there, because they are. We just don't know quite as much about them yet. But I think as we start to do more research on these other genes, we will also know about other genes that may be causing breast cancer and what we can do about that. So how do these genes cause cancers? We all have BRCA1 and we all have BRCA2. It's when you're born with a mistake that's passed down from either your mother or your father that a woman or a man is identified as having a BRCA1 or BRCA1 or BRCA2 mutation. And these genes are there to help protect us from cancer. And when there's a mistake or a mutation in one of these genes, they can't protect us from developing cancer. So these women are much more likely to go on to develop breast cancer. What about how often do we see these mutations? They're relatively rare. In the general population, about 1 in 400 individuals, and that can be men as well as women, have a BRCA1 or 2 mutation. But there are certain groups, like individuals of Ashkenazi Jewish descent, where 1 in 40 individuals may have a BRCA1 or 2 mutation. We also know that women with breast cancer, especially those under the age of 40, are much more likely to have a BRCA1 or BRCA2 mutation, as well as men with breast cancer and any woman who's diagnosed with ovarian cancer at any age. So who then should consider BRCA1 or 2 testing? Typically, we look at the family. So this isn't something that we just look at the individual. We look at what's happening within an individual's family. So we look for young onset breast cancers. Typically, these breast cancers are younger. We look for multiple cases of cancer on one side of the family. So we're either looking on your mother's side or on your father's side. We look for other cancers within the family, like ovarian cancer or male breast cancer. And we also look at ethnicity. And all of this information goes into a decision on whether or not a woman meets criteria for genetic testing, because every province does have criteria that a woman needs to meet in order to be eligible to be tested. So this is what we would see when we see a high-risk family in one of our cancer genetics clinics. And I'm sure many of you have seen what we call a pedigree, and this is a 3-generation pedigree where you can see, and for those of you who have never seen this type of family history, circles are women and squares are men. And I might come back to this. I'm going to pop down again. Is this back on? Okay. So for those of you who haven't seen it, so this is someone that we saw in our clinic. She's 36. If she's shaded in white, that means she's never had cancer. If she's shaded in dark, that means she's had cancer. Here we see breast cancer under 38. So you can see this woman has never had breast cancer. She has a 40-year-old sister, a 43-year-old brother who's never had cancer. Her mother has never had cancer. Her father has never had cancer. But when you start looking at what else is going on in the family, you can see that her father's sister had breast and ovarian cancer. Her father's niece down here had breast cancer at 42, and we see a male breast cancer in the grandfather. So again, a family that's very suggestive that we would find something genetic going on within this family. So if a woman is identified as having a BRCA1 or 2 mutation, and often these risks that we see reported are not specific, and it's very difficult to give a specific risk estimate to a woman because of the way that families were entertained in the earlier research. But we think the breast cancer risk for a woman with a BRCA1 mutation is about a 65% lifetime risk. And we remember we can compare that to the woman in the general population who has about an 11% lifetime risk. BRCA2 is slightly lower, but there are other cancer risks associated with these genes as well. So for BRCA2, we see male breast cancer in some of the men, ovarian cancer in both BRCA1 and BRCA2, and we see an elevated risk of pancreatic cancer in individuals who have a BRCA2 mutation. Not only do we see more cancers within these families, we also see younger cancers within these families. And I think that this is something to remember when we're thinking about when do we need to start thinking about cancer prevention in these women who are identified as high risk. We want to prevent cancers before the cancers are going to occur. So we need to start thinking about this in the 30s and early 40s for these women. Because you can see the average age of breast cancer for a BRCA1 carrier is 42 years, a little bit older for the BRCA2 carrier being 48 years. So why do we do genetic testing? In my mind, there are 4 different things that we want to do. We want to confirm if there's something happening within the family. Is there a genetic predisposition to developing cancer within a family? If we do find that, we can then test other family members to predict who has in fact inherited that genetic mutation and who may be at an increased risk. For those that we do identify as having a BRCA1 or 2 mutation, we can then work with that woman to help her make the right decision for her about breast and ovarian cancer prevention. And if a woman has already had breast cancer and she's identified with a BRCA1 or 2 mutation, we want to be able to personalize her breast cancer treatment so that we can give her the best chance of surviving that breast cancer as well as possibly subsequent breast cancers. So let's talk about the first one, and that's about to confirm and predict. So if we go back to this high-risk family, you remember that this is the woman that we saw in our clinic. So we tested her. She was found to have a BRCA1 mutation. So now we're working with this woman in order to prevent breast cancer and ovarian cancer from happening. We want to reduce her risk as much as possible. But then it also has implications for her family members, because then we can test everybody else for that same mutation. So you see we tested her sister here, I think it's the pointer, her sister here who's positive. So then she's already had breast cancer, so we'd want to talk to her about what the best way is to treat her breast cancer and prevent new cancers from happening, because remember, she also has a risk of ovarian cancer, and we want to prevent her from getting ovarian cancer. We also can tell some individuals within this family that they haven't inherited that genetic mutation, so they are not at high risk of developing breast or ovarian cancer. In fact, they're at the same risk as the general population. Okay, so preventing cancer. So this is something that we work with women who are identified with having a BRCA1 or 2 mutation to make the right decision for them. What are the options that it's available to her? And I'm going to talk about each one of these specifically, but there are preventive surgeries, both a mastectomy or a salpingo-oophorectomy, or medications, which tamoxifen for breast cancer prevention and oral contraceptives for ovarian cancer prevention that I'm not going to talk today about. There are guidelines that have been developed in the US, but we follow these guidelines generally in Canada as well. The NCCN guidelines about what a woman should consider or think about for cancer prevention if she's identified with a BRCA1 or 2 mutation. They say that there are options, including a mastectomy and the use of chemoprevention, which is tamoxifen, that drug I told you about. However, those are options, but they do recommend that women have a prophylactic bilateral salpingo-oophorectomy, which is the removal of the fallopian tubes and the ovaries. This is the only strong recommendation that they do give. They give ages when a woman should consider having this surgery. In order, again, we talked about the ages of the onsets of the cancers. We don't want to delay making this decision until a woman is diagnosed with ovarian cancer, which we know can be happening in the early 40s. So it is recommended that a woman consider having this surgery between the ages of 35 and 40, 40 for a BRCA2 carrier, 35 for a BRCA1 carrier, in order that she can obtain the most benefit from having that type of surgery. So let's talk a little bit about that. What is a prophylactic bilateral salpingo-oophorectomy? This is the removal of the ovaries and the fallopian tubes, and it's very important if a woman is having this surgery that the fallopian tubes are also removed, because there is some thought that the cancers are actually developing in the fallopian tubes as opposed to the ovaries. So it's very important that these are removed. Why should a woman think about removing her ovaries? First of all, there has been research that shows that it significantly reduces her risk of breast cancer as well as ovarian cancer. And recent data, a large international study that came out of our group in Toronto, showed that by having an oophorectomy, a woman with a BRCA1 or 2 mutation can reduce their all-cause mortality by 77%. So this has a huge effect on these women. We can reduce their risk of dying by 77%. So it is definitely recommended that women have this type of surgery when they have completed childbearing. Prophylactic mastectomy is an option. It's something that we talk to women about. For some women, they absolutely want to have this surgery, and for other women, they absolutely do not. We do have good screening for breast cancer, so women who are identified with a BRCA1 or 2 mutation are eligible for MRI screening, like some other high-risk women as well. But we know that prophylactic mastectomy is the option that's going to reduce a woman's risk of developing breast cancer the most. So if a woman says, what can I do to almost guarantee that I will never get breast cancer, the answer would be prophylactic mastectomy. It will offer the most protection. Tamoxifen is a drug that can be taken by high-risk women. It's not just for BRCA1 or 2 carriers. It is for women who are identified as high risk due to other features like a family history without a BRCA1 or 2 mutation. We know from previous research that this drug reduces the risk of breast cancer by about half in high-risk women. We have less evidence about its effectiveness in BRCA1 or 2 carriers just because it's a difficult thing to study. The majority of women do not elect to take tamoxifen, so it is difficult to study. But we do know in looking at women with a BRCA1 mutation who've had breast cancer that it did reduce risk of a new breast cancer in the opposite breast. So there are things that we can do. So this information, and MJ talked about knowledge being power, there are options for women that we can significantly reduce the risk of getting both breast and ovarian cancer. And again, this is a great advantage of genetic testing. So what about the woman who has previously been diagnosed with breast cancer? Is it important that they have testing for BRCA1 and 2 because they have already had cancer? So what more is it that they can do? And I'm going to show you some data today that I think will help to answer some of those questions. And when we first started out doing this research, we were really wondering, should women with a BRCA1 or 2 mutation receive the same treatment as a woman who doesn't have a BRCA1 or 2 mutation? Should we be tailoring the treatment based on the genetic information? So when we first started looking at this, we were looking at women from across North America who had a BRCA1 or 2 mutation who had been diagnosed with breast cancer. And we followed close to 900 women for almost 20 years to see what happened to those women in the 20 years and how did their treatments affect things like the risk of a new breast cancer. So this is looking at the risk of an ipsilateral breast cancer. So that's a cancer in the same breast that the cancer was originally diagnosed in. And you can see over 15 years, these women have a 16% risk of developing a new breast cancer. This isn't a recurrence. This is a new breast cancer in the same breast. So a 16% risk. In the opposite breast, she has about a 34% risk of developing a new breast cancer in the opposite breast within 15 years. So this was giving us some more evidence that we need to think about these risks differently. We need to think about not just treating the first breast cancer, but also preventing the second breast cancer because they have such a high lifetime risk of going on to develop a new cancer. And remember, these women are being diagnosed at a young age, so they have a long time to still live. So again, this is small print, but this is a paper that we looked at because really, what do we want to do? We want to make sure that these women survive their breast cancer. And what we saw was that by certain treatments, certain surgical treatments, we could significantly reduce the risk of that woman dying of breast cancer. So you can see there that an oophorectomy, so the removal of the ovaries, reduced her risk of dying by 53%. And by having a bilateral mastectomy, so removing both breasts at the time of that initial breast cancer, she reduced her risk of dying of breast cancer by 41%. So I think that this really speaks to, yes, knowing genetic status at the time of breast cancer diagnosis is really important. And we do have a study now that's ongoing in Toronto where we are offering rapid genetic testing, so these women get results back within 10 business days at the time of breast cancer diagnosis before they're making their surgical decisions so that they can elect to have some of these surgeries like a bilateral mastectomy as part of their initial treatment. So I just talked about that. So in conclusion then, genetic testing we know is identifying women at high risk of developing a first breast cancer, high risk of developing an ovarian cancer, and high risk of developing a subsequent breast cancer. We can do something with this information, though. It isn't just something that we would put on the bookshelf after we're told that we have a mutation in one of these genes. We can identify other members in the family so that we can prevent cancers from happening in those other members. And we can elect for cancer risk reduction options that are going to decrease the cancer risk, but also increase survival in these women, even if they've never been diagnosed with cancer in the past. And if she has been diagnosed with breast cancer, we can target treatments so that we can reduce the risk of developing new cancers, and we can also reduce the risk of a woman dying of her disease. So I'd like to thank you and to thank all of the women who have taken part in all of the research that I presented today, because without all of those women, we could never be doing this research and we wouldn't be able to be bringing it to you tonight. So thank you. Do I stay here? I think they turn it on.
Does anybody have any questions for Kelly? Dr. Metcalf, I should say.
Oh, it's Kelly.
I come from a very high-risk family.
Yes.
With 12 children. 5 of the 7 sisters have breast cancer. The 6th one has ovarian cancer. 4 of the 5 brothers died of cancer. And I was tested for the BRCA1 and BRCA2, and it was inconclusive. And why?
Have you had breast cancer?
Yeah, I have had a mastectomy.
Okay. So sometimes it happens within a family, so it would still be important to test other members of your family who have had breast cancer, because we do have families where there is a BRCA1 or 2 mutation that can account for the majority of cancers, and someone like yourself who's had breast cancer within that family, we test and is negative, and it's just a sporadic breast cancer that's happening within a hereditary cancer family. There are also other genes that we have discovered more recently, and we're starting to know a little bit more about the clinical implications. So it may be worth a revisit to your genetic counselor to talk to them about some of these new genes that are available for testing.
What risk do my nieces run?
It would be based on your family history, so they would even though you've had a negative BRCA1 or 2 mutation, you still have a very significant family history. So your nieces would still have that elevated risk of developing breast cancer just based on their family history alone.
Should they have any, should they have their breasts removed or ovaries removed?
That would be something that they would have to discuss with their physician about whether or not that would be warranted based on what risk that has been assigned to them based on the family history. You're welcome.
Thank you.
Mm-hmm.
So actually, I just wanted to say, if you've had BRCA1 and 2 testing many years ago, that we have newer techniques to look at those genes. So you might want to call your genetic counselor and update your BRCA1 and 2 testing. If it was negative several years ago, maybe the newer techniques might pick something up. Inconclusive? Okay. So it's always important to contact your genetic counselor to see if there's any new information about your specific result.
So that was Sonia Nanda, who's a genetic counselor, and she's going to be speaking later today. Does anybody else have any questions? I'll come back to you in a moment.
I'm just curious who you feel should prescribe the tamoxifen.
That's a good question. And I have sat on a panel recently where it has been thrown out there that the family physicians don't want to do it. But generally, if you have access to a high-risk clinic, do you live in Toronto? No. Do you live close to Toronto? So for high risk,
I'm a physician myself.
Oh, you are.
And so I kind of represent a lot of the areas and access to such testing.
It is difficult.
And know that it's very difficult. And also the genetic clinics don't actually accept a second referral back for that idea.
For tamoxifen?
No, for the second BRCA testing.
Oh.
They've already had it, it's
that.
negative, and they just refuse again.
Yeah.
So
no.
we do face them. But
yeah,
I'm
but
very
the tamoxifen,
curious
it is something that, so I was just working with Cancer Care Ontario to look at developing a pathway for individuals who are at high risk, and it came up about who does want to follow these patients, because we can't be referring them to surgeons to follow them. We can't refer them to an oncologist because they've never had cancer. So unfortunately, it may be an access issue, but that there are high-risk clinics in a lot of the major centers that will follow the women who are at high risk, and they will prescribe tamoxifen and follow those patients.
Okay, I think there was a question over here.
Yes, I have a strong family history of breast cancer, but I don't have the breast cancer gene. And I also have a strong personal history with 3 breast cancers, all caught very early, 10 years apart. In the last diagnosis, I came up with conflicting advice. One doctor saying it's too high a price to have a bilateral mastectomy, another one saying that if I didn't have it, I was gambling with my life. Is there any way in my situation of assessing what my risk is?
It's a very difficult, and I think a personal decision, because we don't have that absolutely, yes, you're at high risk. But you do have a significant family history, and you've had 3 breast cancers. So, I'm not going to say what I think you should do, but it would be a personal decision. I'm more than happy to talk to you after.
Yeah, is there somebody any kind of expert who could help me put a number on my risk?
I don't think the risk models would take into consideration the number of cancers you've had. So it is difficult, and it's not common. So it would be difficult to put a number on your risk. It's very difficult to assign an absolute number risk to anybody, because we all have competing, and I think Dr. Simard is going to talk about that a little bit after, about being able to assign risk based on multiple factors, because it isn't just one. We all have numerous. We may have a family history, but we may have a BMI higher. We may not drink alcohol. There's so many different things that could go into our risk.
Thank you. And what about Arimidex? You mentioned tamoxifen. Do you have any studies on the risk reduction of Arimidex?
No, we don't yet.
Okay, thank you.
Are there any more questions for Dr. Kelly Metcalfe?
I'll be around too, so I don't know
Okay.
how we are with time.
Yeah, how much more time do we have? One more question? Okay, here you go.
My mother had breast cancer as well. Her identical twin sister did. Does that increase the risk at all?
Have they had how old were they?
One was premenopause, one was postmenopause.
They should be assessed in a cancer genetics clinic.
Well, they both passed
they-
away. So now my sister and I are here and want to know
Right.
about.
It is worth going to see a genetic counselor, because they could look at whether or not you meet criteria. And I think that 2 first-degree relatives, 1 under 50, no, greater. So they would look at your risk. So there may be other relatives within your family too that they would look at that. But yes, I think it's worth a visit to a genetic counselor.
Okay, thank you.
Thank you.